Assalamu alaikum. Welcome to our next session. So in this sessions, again, I think we will be discussing 4 scenarios. So starting from Sir NT, you will be the examiner, Dr. Amir, you will be the candidate.
Right, sir.
Amir, a 42-year-old male patient has reported to you in OPD with complaints of a swelling in front of the neck on the left side. How will you proceed?
In this case, I would perform a clinical assessment. I would obtain detailed history. Most probably, this patient is having a thyroid swelling, and I would obtain history about toxicity, features of malignancy, local invasion, or distant complications like distant metastasis. I would also inquire about the risk factors. Moreover, I would be I would rule out other diagnoses like secondary mets, lymphadenopathy, or cervical lymphadenopathy in this case as well. I would perform a systemic inquiry, and then I would perform a detailed examination of the neck.
Okay. After examination, you determine that there is a solitary nodule about 7 by 5 centimeter in left lobe of thyroid.
7 by 5
centimeter.
7 by 5 centimeter in the left
lobe of thyroid, solitary nodule. So how will you proceed now?
So it's a large nodule, and it's a solitary. I would get first I would send baselines, and I would get thyroid function tests. Then I would request for ultrasound in order to know the Bethesda classification. Thyroid's classification, and then later on I would request FNSE in this case.
Okay, the FNSE report comes out to be it's a follicular adenoma. How will you proceed now? Thyroid function tests are normal. FNSE shows follicular adenoma.
Well, it's difficult to differentiate follicular carcinoma on the basis of FNSE. So after anesthesia assessment, I would also like to know, before this, I would also like to know whether it's a functional thyroid or whether there are or not.
What is your movement?
So then in this case, I would go for a diagnostic lobectomy with this mastectomy in this case.
Okay. Which lobectomy?
Left-sided lobectomy, since the swelling is in the left side. So,
okay. So after you have done the surgery, the histopath report comes out to be follicular carcinoma, which is about 4 by 4 centimeter in size. So what is your next step now?
The next step would be a discussion of this patient in the tumor board meeting. I would involve multidisciplinary colleagues and discuss this patient in the tumor board meeting. Most probably, the board would recommend completion thyroidectomy in this case. I would inform the patient about the tumor board recommendations and discuss with the patient. Since he is a young patient with a large swelling, and I would also like to know what is the histological grade of this swelling, and whether there is any lymphovascular invasion on the histopath or not. And based upon these features, most probably, the tumor board would recommend completion thyroidectomy, and after counseling the patient, I would go for completion thyroidectomy in this case.
So you have decided for completion thyroidectomy. How soon will you do it, and what else will you explain to the patient?
In this case, the completion thyroidectomy, since the other lobe is sort of unexplored and the area is virgin, so it would be done from the same NCN, and flaps would be raised. Deep cervical fascia would be opened longitudinally as previously.
What? How will you counsel the patient preoperatively about this second surgery? What special points will you mention to him?
Well, first thing would be to break the bad news, because the patient has been diagnosed with carcinoma. Moreover, I would explain him the risks of recurrent laryngeal nerve injury. That would be around 1%. Similarly, I would also explain him the risk of permanent hypocalcemia. That would be also 0.5%. Moreover, the patient will have to take lifelong thyroxine, and he might have to, he will be undergoing radio active iodine ablation as well. So all these things would be kept in mind and told to the patient once he comes for the counseling session.
Okay, so you have done the surgery, and now it's second post-op day, and the duty nurse, she calls you that the patient is having spasm of his hands. So what will you do, and what do you suspect? How will you examine? What will you do?
My first suspicion in this case would be hypocalcemia. So in this case, I would again perform examination. I would send a sample for calcium levels.
What signs on examination you will see?
On clinical examination, I would look for Shefstech sign and Trozier sign and carpopedal spasm. So if these signs are present, I would go for intravenous calcium administration.
Okay. How will you give calcium?
It's calcium gluconate 10 ml is given in 100 ml normal saline over a period of 1 hour, 30 minutes to 1 hour. And if this is, then I would replace the calcium with, I would start the patient on oral calcium as well, by calcium carbonate 500 milligram TDS for a couple of days.
Okay. Okay, so the patient gets well and is discharged. How will you tell him to follow up, and what advice will you give on discharge, and what follow up will you tell him?
This is a patient who has been operated upon with malignancy. I would counsel him about follow up with the histopathology report. I would tell him about the post-operative care, when to return to hospital for emergency care in case of emergency. Moreover, I would tell him the usual advice of dressing, and I would prescribe him thyroxine as well.
ठीक है. Okay, ठीक है. Shwakat?
So, Amir, I have one question. So
Sir.
you rightly answered the questions. You've systematically gone through the scenario. And I have one question. So you mentioned that you would go for the ultrasound and followed by the FNC. So what are the indications of FNC in case of solitary nodule?
Indications for FNSE.
FNC.
Indications of FNSE are basically the ultrasonic features, like if there are solid and cystic components, if there is architectural distortion, if there is a taller than wider features, if the swelling is hypoechoic, all these features they represent malignant features. So in this case, FNSE is indicated.
Okay. So the gold standard nowadays, it's a gold standard investigation for evaluating the nodules of the thyroid. So on the ultrasound, they classify these lesions. So if it's a thyroid type 0, 1, or 2, up to the benign, so there is no indication of getting the FNSE. So if it's a thyroid 3, that means it's probably benign. No, that's an indication for the FNSE. So if it's clear-cut benign, there is no indication of FNSE. So you need to ask the examiners what is the ultrasonic features of this mass, right? Number one, and number two. Yeah.
Solitary
Yeah.
में भी हर केस में FNSE नहीं करेंगे.
No, sir.
नहीं सर, हर केस में नहीं करेंगे.
No. So the ultrasound is the gold standard. For the give you clearly what is the vascularity, and the invasion, everything. You can visualize it on the ultrasound. So they classify into different categories, just like FNSE classification. So if it's a grade 3, thyroid 3, then it's indication for the FNSE. So if on the ultrasound it looks benign, so they don't recommend even the FNSE. These are the current recommendations.
Okay, Dr. Amir, you have done thyroidectomy. After 2 years of follow-up, patient began to rise. On 2-year follow-up, there is a rise in thyroglobulin levels post-operatively.
So thyroglobulin level was not advised initially.
Yes,
So
I want to mention that. And secondly, you have post-operatively patient has to undergo a thyroid scan to see the distant mets, because post-operatively you have to make patient hypothyroid, or you have to give recombinant TSH to make CA, because follicular carcinoma has a metastatic spread, and pre-operatively you can assess, and post-operatively you have to undergo total body iodine scanning by after making a patient hypothyroid, so that if there is any distant mets, then you can give him post-operative radioactive iodine therapy. Dr. Shafkat, would you like to add something to my comment, please?
मैं thyroxine तो फिर भी देंगे ना, अगर आपने उसको वो करना है, hypothyroid करना है तो.
हाँ, when the NT was asking him, so during the follow-up, what will you advise the patient? So at that time, so that needs to be incorporated. Yes, you need to tell the patient, yes, we have an appointment with the nuclear medicine, because the next step is to get your scan, radio iodine scan. So technician 99 scans just to see what is the remnant which is left behind, and afterwards, is there any distant mets, so that we can ablate it. So that is the most important aspect of his follow-up. And similarly, the long-term follow-up, you need to inform the patient he needs to be he needs to visit the clinics. So the timing of the visits, that needs to be informed to the patient.
Secondly, I would like to add one thing more, that after post-operatively you have to get your baseline thyroglobulin levels for future reference. So yes, post-operatively after 1 month, you should have baseline thyroglobulin levels, so that if there is any recurrence, you should know that what was the baseline thyroglobulin level for follow-up.
Okay, is there a possibility that the thyroglobulin level is normal and the patient is having a recurrent disease, differentiated thyroid carcinoma?
Yes, there is possibility.
Yeah, Ji Amir. Is there a possibility? There is a recurrence. There is a recurrence of the differentiated thyroid carcinoma but the thyroglobulin level is normal.
Sir, मेरे इल्म में नहीं है.
So if the antithyroglobulin antibodies, they are positive, then the thyroglobulin will level, they will not be raised. So you need to check the thyroglobulin and antithyroglobulin antibodies before doing the surgery. That baseline investigation.
थायरोग्लोबुलिन जो है सर ये तो वो ओमिट हुई है. बाकी जो
और antibody
स्कैन है इट्स डन एट 6 वीक्स, तो वो उस पे इमीडिएट पोस्ट ऑपरेटिव पीरियड में नहीं आता, इमीडिएट फॉलोअप में जब आप उसको पहली दफा. लेकिन जब वो हिस्टोपैथ के बाद आएगा तो देन वी विल काउंसल हिम अबाउट द स्कैन और बाकी चीजें.
Because in differentiated thyroid cancer, post whole body scanning followed by, even for thyroid remnant, you need to give post-operative radiotherapy, because it will surgery will remove big disease. So in my opinion, patient should be given radioactive iodine if he or she has a differentiated thyroid cancer.
Yes, radioactive iodine therapy is to be given in follicular cancer in any case. It's not given in low risk papillary thyroid cancers nowadays. If it is a high risk papillary cancer or intermediate risk cancer, then even then we will give. So low risk and high risk, broadly there are two categories. If there is low risk, then we can avoid radioactive iodine. In that they say that if there are low risk features, then just lobectomy is enough treatment, and there is no need for completion thyroidectomy, no need for radioactive iodine, and no need for lymph node dissection.
Right.
So Baki, yeah, Amir.
So on the second post-op day, hypocalcemia. So you mentioned that you will send the sample for the calcium. So can you elaborate?
Yes, because the patient is experiencing a carpopedal spasm. He is experiencing symptoms of hypocalcemia. So his levels at calcium levels at that point are very important to be measured. So I would send the levels to see that whether there is transient
you will write
hypocalcemia.
serum calcium, right? You will write the serum calcium, your request for the serum calcium.
Yes. Ionized as well as ionized as well as non.
As well
ionized as well as non-ionized calcium level.
Okay, the facility for the ionized calcium, suppose it's not available, then?
So then it's generally total calcium level.
Total calcium. That is there any possibility the total calcium can be falsely? It's giving the reading. It's normal. It's high or low. Is there any factor?
Yes, basically the unbound calcium, ionized calcium, that is active calcium, and its level basically they matter. But the test is done by, I think, radio immunoassay or something like that. So it's most of the time it's not available. So that
if it's not available, then what you can do? So
total
just
calcium level.
Calcium along with ask for the albumin level. Then you can
level के साथ adjust करना होता है.
Yes. So corrected calcium. So you will send the calcium for total calcium along with the albumin. If it's facilities available, you can send them ionized calcium. And similarly, what are the adverse effects of calcium gluconate? You administered the calcium gluconate in this patient. So can you tell me what you are going to instruct your nursing staff while administering the calcium?
It has to be given slowly over a period of 30 minutes to 1 hour, and it can have adverse effects on heart and neuromuscular junction. So they should keep
patient
the
can
patient
develop cardiac arrest. Right.
Okay. They should monitor the patient while giving calcium.
Okay, fine. I think there's sufficient Do you have any other questions? Otherwise, we will move to the next slide.
हिस्ट्री में आमिर,
Yeah.
हिस्ट्री में ना थोड़ा सा स्वेलिंग का तूने जिक्र नहीं किया कि स्वेलिंग की हिस्ट्री भी जो है ना इम्पोर्टेंट होती है।
जी बिल्कुल सही है, हाँ, सही हो गया।
और
So
एग्जामिनेशन में तूने सिम्टम्स का जिक्र नहीं किया मेरे ख्याल में, एग्जामिनेशन में वो सॉरी हिस्ट्री में प्रेशर सिम्टम्स का जिक्र नहीं किया।
लोकल सिम्टम्स का तो मैंने किया, लेकिन वही लोकल कॉम्प्लिकेशंस में ये मैं जो है आप कह लें स्वेलिंग और एसोसिएटेड फीचर्स जो है ना वो भूल गया, वो करना चाहिए।
Okay, I noticed that. So once you were given the scenario, so you assume that it is a thyroid swelling. So you started with I will ask if this is related to the toxicity, malignancy. Then I will ask the systemic inquiry. Later on you ask, yes, I will keep in mind that, for example, lymphadenopathy could be cervical lymphadenopathy. To begin with, if you can ask him, I would like to check during history. I would like to check whether this swelling moves with the debilitation or not. If it moves with the debilitation, then my history will be focusing on the thyroid. So it could be the examiner may change the scenario. So everything you are relating to the thyroid. So actually it's non-thyroid swelling. Okay.
This is a possibility.
Yeah. Okay. So should we move to the next scenario?
ठीक है आगे चल।
So who is going to Usman? You are going to be examiner?
Yes.
Okay, please go ahead.
Okay, Dr. Amir, you have a 48-year-old man. He is presented with in medical OPD and referred to you for persistent hypertension. His blood pressure is on examination. His blood pressure is 170/90. His pulse rate is normal, and he has been taking multiple antihypertensive drugs. His laboratory reveals normal renal function test, except he has hypokalemia and hypernatremia. She also complained of nausea and vomiting. And how would you proceed with this case?
Well, this is a case of resistant hypertension in a young patient that is refractory to multiple antihypertensive drugs. In this case, I would be most probably dealing with pheochromocytoma or Cushing's disease. So I would obtain a detailed history of this patient, and after performing thorough examination, I would like to go for baselines and biochemical tests in this case.
Okay, his biochemical tests reveal increase in serum. His urinary metanephrines are normal, and his yes,
24-hour
yes,
metanephrines are normal,
and he has raised renin and aldosterone ratio. So what would be your diagnosis? How would you proceed?
So it's basically a primary hyperaldosteronism. Most probably, I would look for the ratio of aldosterone versus renin. I would also perform a serum cortisol assessment. I would look for the electrolytes. Serum
Electrolytes reveal that he has hypokalemia. His serum potassium is 3.8, and his serum sodium is 154 milliequivalent per liter.
So most probably he is having hyperaldosteronism, and for that I would like to localize the lesion with the adrenal protocol CT scan.
Okay, CT scan reveal a 5 into 5 centimeter adrenal mass in adrenal cortex.
So the next step would be to prepare the patient, optimize the patient, and arrange blood, counsel the patient, and
How
involve.
would you optimize the patient?
In this case, I would control his hypertension, optimize him by sending him to internal medicine specialist. Moreover, I would discuss this patient in the multidisciplinary team meeting. I would involve endocrinology and endocrine surgeon in this case, and I would arrange blood uh, and then correct his electrolyte abnormalities, and then I
Okay,
would.
yes, after that, what would you do? Patient blood pressure has been controlled with angiotensin receptor blockers and calcium
Then
channel
I would
blockers.
offer this
And
patient. Lep- the size of the tumor was 5 centimeter.
5.5 centimeter.
Yes. So along with the uh, endocrine surgeon, I would take this as a joint venture. I would involve the endocrine surgeon and offer laparoscopic adrenalectomy to this patient.
Okay, how would you do the laparoscopic adrenalectomy?
In the laparoscopic adrenalectomy, the patient would be placed in the lateral position, and ports would be placed in the subcostal uh, uh, area. Uh,
What type of laparoscopic adrenalectomy you would offer him? Retroperitoneal or intraperitoneal?
Intraperitoneal. So I've not seen any retroperitoneal adrenalectomy. Uh, though I don't perform this surgery, that's why I would involve endocrine surgeon in this case. And in this case, we would take down splenic flexure,
Okay.
uh, and we would go into the retroperitoneal area. And
Okay. During dissection, you damaged renal pedicle while ligating adrenal vein. While separating adrenal vein, you have damaged and there is abrupt bleeding that has started because of your dissection. What
so
would you do?
the bleeding is torrential from renal pedicle. I would, in conjunction with my endocrinology colleague, convert this patient to open approach, and I would also call for vascular. In this case, I would evaluate the bleeding, uh, place a gauze, and apply pressure in order to control the bleeding from the site. Meanwhile, I would assess uh, the surgical field, and normal to and it looks normal anatomically to palpation.
Okay, the
So
bleeding
once
has
the
been controlled and you have successfully done adrenalectomy. What would you do post-operatively?
post-operatively, these patients have to be monitored for any signs of hypertension. They may develop hypertension. So, moreover, antihypertensive drugs, they are tapered off once the patient starts clearing adrenocortical hormonal excess hormones from his body. So later on, the drugs are tapered slowly.
Okay, how would you follow up this patient?
The follow-up, I would follow him up with the histopath, and I would see that whether it's benign or malignant swelling.
Okay, histopathology revealed adrenal adenocarcinoma.
Uh, then I would look for the evidence of margins. I would look for margins, whether they are involved or not involved. And if they are not involved, then I would just keep the patient on follow-up. And if there is involvement of the margins, then I would discuss the case with surgical and oncology colleague. And after discussion in the multidisciplinary team meeting, we will most probably go for re-XCL of the surgical field.
Okay, thank you very much. Okay, sir, house is open for discussion.
Again, a very good scenario. Dr. Swan, you have designed a very good scenario. So, a few observations. Obviously, again, Amir has responded very well to the Dr. Usman. Starting with your differential diagnosis, with the patient who is having a resistant hypertension, have persistently high blood pressure, patients taking multiple antihypertensive medication. So examiner is giving you the hint that this patient is hypokalemia, hypernatremia. So the first diagnosis should be the hyperaldosteronism, Cohn syndrome. So the second one, the renal artery stenosis. So these two diagnoses, they should be at the top. And then you can say, yeah, it could be pheochromocytoma and other things as well.
I have intentionally switched the scenario from pheochromocytoma to Cohn's adenoma
So starting
because
from, okay.
because our natural instinct is that whenever we think of blood pressure, our first diagnosis is pheochromocytoma, adrenal medullary carcinoma.
Or
We
more
forget, yes, we forget normally adrenal cortical tumors. We always have to keep in mind adrenal cortical tumors as well. It can present as a scenario in the case of virilization syndrome in the females. If it is a tumor of adrenal glomerulosa, then adrenal fasciculata, Cohn syndrome, and reticularis, that is Cushing syndrome. We also always have to keep in mind that there are three portions of adrenal cortex. Glomerulosa secrete aldosterone, if I am correct.
Yes, mineralocorticoids. Yes.
Mineralocorticoids. Fasciculata secrete androgens,
Glucocorticoids.
and glucocorticoids, and fasciculata secretes androgens. And adrenal medulla secretes catecholamines. So with adrenal medulla and adrenal cortical tumor, both can present with hypertension. So differentiating point is, as I mentioned, that it is potassium or sodium, which we have to keep in mind.
And similarly,
potassium, sodium, and then aldosterone and renin.
Yes, renin and
it's 20 ratio 1, more than
yes.
that.
And secondly, the preoperative management of these two different hypertension is different. In adrenal medullary pheochromocytoma, preoperatively we have to give phenoxybenzamine and beta blockers because it is a catecholamine disease. And in adrenal cortex, preoperatively we have to give angiotensin receptor blockers.
बिल्कुल सही है.
So I think Dr. Shafkat or Dr. Noman will make us wise on the subject further. They want to add something more.
So similarly, thank you, Usman. Similarly, there are other conditions which are the reason for the resistant hypertension, which is not responding to the antihypertensive medication. So, for example, aortic dissection, and so the needs to be discussed with the internal medicine colleagues. Okay, that's fine. So you started off with this the diagnosis, and the examiner gave you the data, laboratory data. This urinary is 24-hour urinary metanephrine, that's normal. And again, he stressed upon, yes, the ratio, renin aldosterone ratio. He mentioned about that. Okay, if you asked me the CT scan with the adrenal protocol, examiner gave you the scenario, it's a 5 into 5 centimeter, 5.5 centimeter. So I think you must ask more information. So whenever there's a mass which is more than 4 centimeters, 25% chance of a malignancy. So in
Ounce
this,
field unit का basically पूछना चाहिए.
you can ask them whether there are any features which are suggesting the malignancy. What is the Ounce field density of this lesion? So is there any features which are suggesting the malignancy? I will discuss with my radiologist. So because of the 5.5 centimeter Cohen syndrome, actually it's 2 to 3 centimeter only lesion most of the time. They're very small. So
Because
that was
it's I would wanted to highlight the case that it's a adrenal carcinoma. So in this case, you have to do radical adrenalectomy with urology colleagues. You probably have to involve urologist as well, because tumor of this size, it usually invade kidney as well and perinephric fascia. If you have to do radical adrenalectomy, then I think urological consult is will be very helpful in this case.
Yeah.
In addition to your vascular surgeon and endocrine surgeon, you also
I
must.
involved surgical oncologist.
Yes.
Yeah.
Uh,
Okay.
Surgical oncologist, they basically operate cancers.
Okay. So
and secondly,
more
on
thing is,
adrenals, we also keep that adrenal is a favored site for metastasis of many cancers. Many metastatic cancers, they occur in adrenal. So always we should keep in mind that adrenal is site of many secondaries. When there is some incidental mass, it was a clear-cut case of Cohen's adenoma. Otherwise, if there is a simple incidental adrenal mass, it can be metastasis from breast or I think ovary, and many cancers, they metastasize as a secondary to adrenal gland.
Yes, even from renal cell carcinoma, they can
Renal cell
metastasize.
carcinoma.
right.
Yes.
So that's great. Okay. So at the same time, the patient patient is also symptomatic. This patient is having episodes of the vomiting. He's complaining of nausea and vomiting. You need to address his symptoms as well. So while investigating, so you need to mention that I will take care of the her complaints and you give them resuscitate whatever the treatment you will advise. Okay. Is there anything from Dr. Noman? Sir Noman. Okay, no, you are muted. Let me unmute you. Yeah, sir.
ठीक है यार, आगे चल. ठीक है,
अच्छा
हो गया.
ठीक हो गया जी, जबरदस्त. चलें जी. Now this is
इसमें ये बता, इसमें सिर्फ ये बता दे, रेडिकल एड्रेनलेक्टमी में आप नेफ्रेक्टमी भी करते हैं साथ?
सर मेरा ख्याल है करते हैं उसमें नेफ्रेक्टमी, ये किडनी इन्वॉल्व होता है इसमें. इसमें क्योंकि लिम्फ नोड भी साथ निकालने होते हैं और पूरा एनब्लॉक जेरोटा फेशिया और जो पूरा एरिया ना वो निकालना होता है इसमें
और
एनब्लॉक.
ये आप लेप्रोस्कोपिक
क्योंकि
ही
इसकी
कर सकते हैं, मतलब लेप्रोस्कोपिक करते हैं ये?
नहीं सर, इसमें जो है फिर ओपन होगा. जो malignancy है, अगर malignancy है तो that is one of the contraindications to laparoscopic surgery in adrenals.
वाई?
और फिर दूसरी चीज है साइज है 8
पोर्ट
सेंटीमीटर.
साइज सर, एक साइज बड़ा है. और सेकेंडली पोर्ट साइट भी जो है ना, मेटसेट्स का इसमें मेरा ख्याल रिस्क होता है.
इसमें and और इतने ट्यूमर को करना, रिसेक्ट करना, it's oncologically you can say that it's not safe. I
सर
think
इसमें आप कह लें कि अभी थोड़ी सी स्किल्स अभी नहीं बनी. आप कह लें, ये कह लें
ज्यादा नहीं है ना.
स्किल्स अभी जो है शायद एड्रीनल
Yes.
सर्जरी में बेसिक लेवल पे हैं या उसके ऊपर हैं.
Yeah, you're
क्योंकि कुछ
exactly.
अर्सा पहले तक कोलोनिक सर्जरी में भी यही कहते थे कि
ऐसे
जो
थे.
कि जी अगर आपने कैंसर का किया तो वो नहीं है, ठीक नहीं है.
Exactly.
उसमें रिकरेंस के चांस ज्यादा हैं, रिजल्ट्स अच्छे नहीं हैं, पोर्ट साइट वो कर देंगे. फिर बाद में उन्होंने पोर्ट साइट को तो खत्म कर दिया. लेकिन अभी इसमें है
Yeah,
कि जी अगर
exactly.
malignancy है तो
इसमें
फिर
ओपन करना. Exactly. यही
malignancy
मेन.
है.
चलिए जी, लास्ट सिनेरियो
malignancy-
कर लेते हैं अभी.
ठीक होगा सर.
Okay. A 40-year male patient has presented to you in the your outdoor department with the 3 months history of repeated episode of vomiting and weight loss. Now, how will you assess this patient and what will you do?
There are two symptoms only: vomiting and weight loss.
And weight loss. He's having a repeated episode of vomiting.
This patient has non-specific symptoms. Upper GI, most probably I would be suspecting some upper GI pathology in this case. I would like to obtain a detailed history and perform a thorough examination. I would like to know that whether this patient has any history of dysphagia, any history of reflux, retrosternal retrosternal discomfort.
No.
Is the patient having jaundice?
No.
Has the patient had any episode of hematemesis or melena?
No hematemesis. No melena.
And the patient is he? I would also be interested to know whether he is suffering from any chronic.
No, he's apart from he's only a diabetic, but otherwise he's fine. There are no known comorbids.
There are no comorbids. So after obtaining detailed history, exploring all the symptoms, I would like to request baselines in this patient.
So would you like to
And
perform a physical examination as well?
Yes, after detailed history and physical
So
examination.
what other question were you asked during the history?
I would be interested to know that whether this patient has any pain in the epigastrium or any part of the abdomen, whether the patient is having any features of constipation, whether he is having any history of abdominal distension.
No abdominal distension, he's not having any pain. He used to pass stool after 3 days, 3 to 4 days.
Okay. And I would like to know about his past history of any ailments or surgeries.
There's no history of any previous surgical intervention.
Okay. So in this case, after performing I would perform abdominal examination.
Yeah.
And I would look for any palpable masses, specifically any evidence of herniations, any evidence of tenderness.
No tenderness. There's no tenderness. There's no palpable mass.
And is there any evidence of ascites or not?
No.
So this patient needs further investigation. I would get baselines, and I would be interested to know his findings on CBC and electrolytes, liver function test.
HB is 9 gram per deciliter.
So he is anemic.
Yeah.
I would like to know the LFTs and RFTs as well.
LFTs are normal. LFTs are normal. They are normal. So urea is slightly raised, otherwise the creatinine is normal.
So the next step would be to perform ultrasound abdomen and request upper GI endoscopy.
Upper GI endoscopy. So what are you suspecting?
It can be some ulcer or some erosion in the stomach or esophagus, or it can be even some form of malignancy that is causing anemia in this patient.
Okay. So the upper GI endoscopy has been done. It reveals that there is a growth at the distal part of the stomach, and the scope cannot be negotiated.
So I would request endoscopists to take biopsies, multiple biopsies.
So he has taken the biopsies, and histopathology reveals adenocarcinoma of the stomach.
Adenocarcinoma of the stomach. So I would correct this patient's anemia. I would correct his abnormalities related to vomiting, and moreover, I would stage the disease. I would perform. I would request for a chest and abdominal CT scan, endoscopic ultrasound, and
Why?
followed by this.
So at the same time, you will request for the CT scan and US at the same time.
They can be done in the different. They would be done in the different time frames, but
Okay.
for evaluation of the nodes and metastasis, I would perform and getting an idea of the T stage, I would perform CT scan. For T stage, I would be I would prefer endoscopic ultrasound.
Okay, the CT scan shows, CT scan abdominal pelvis shows that the stomach wall is thickened at the antrum, and there is no liver mets and there is no ascites. So the EUS has been performed. It shows it's E2 lesion with the involvement of the lymph nodes are involved in the suprapyloric region.
So most probably it's T2N1 disease. I would discuss this patient in multidisciplinary tumor board meeting. I would involve upper GI surgery colleagues in this case, and along with surgical oncologists. And this patient would require distal gastrectomy after optimization.
So you go for the distal gastrectomy, right? So how will you go? Will you go open through open approach, laparoscopic? What will you do?
Well, this is depending upon this patient's it's a surgery with curative intent, and it requires extensive resection. We would go with open approach, and we would resect.
Okay, now you have opened up the abdomen. You notice that there are small nodules on the liver. You have opened with the laparotomy. There are small nodules on the liver. Now, what will you do?
Well, I forgot to mention that we would pre-op also go for diagnostic laparoscopy in this
Laparoscopy?
case.
Okay, so you have done the laparoscopy. So for suppose there are no liver mets on the diagnostic laparoscopy. There are no liver mets.
So then we can go with the curative intention through the midline exploration.
Is there any other thing which you should be doing while doing the laparoscopy?
Yes, we'll take biopsies, take peritoneal samples.
And send them for cytology.
Yeah, peritoneal cytology.
Okay, right. So there are no mets, liver mets, and the cytology is negative. What will be next step?
Then the next step would be discussion again in the multidisciplinary tumor board meeting, and we would go for curative gastrectomy, subtotal gastrectomy in this patient.
So what step will you take? Right. So what step will you take?
The first step would be to gain exposure by chevron or midline exposure in CN, and then perform systematic.
Would you like to assess? We would like to perform the nutritional assessment.
Yes, I said that after optimization of the patient. So that involves nutritional optimization, counseling, nutritional optimization, correction of electrolyte abnormalities, rehydration of the patient, correction of the anemia.
Okay.
So, and arranging blood. So these all
right.
After these
so now you have opened up. You have opened the abdomen. So just to see the stomach is it's. What will you do? How will you assess?
I would.
How will you perform the subtotal gastrectomy?
I would assess the first of all. There would be 3 stages in this surgery. First stage will be to assessment stage, or in which I would inspect the whole abdomen for any evidence of mets. or peritoneal deposits. I would assess the growth and its size and location and its extent into the local and surrounding tissues. I would assess for the lymph node involvement per op.
Okay. Okay. So
And
suppose this growth is fixed with the posterior abdominal wall, and you cannot do it with the curative intent. Then what will you do?
then this would be a palliative procedure in which I would
Yeah.
I would leave the tumor there, and I would perform gastrojejunostomy.
Gastrostomy. Okay, but even that stomach growth has extended so above, it's very high. So you are unable to get the stomach for making anastomosis. Now what will you do? It's involving almost whole of the stomach. What will you do?
So if the whole of the stomach is involved, then we will
Almost.
have to perform. Then we'll perform feeding jejunostomy.
Okay.
Because
Okay.
we'll perform feeding jejunostomy.
Any other thing which you can do for the stomach?
Then we can perform esophagojejunostomy as a bypass procedure.
Okay.
Or palliative resection can be done if it is not fixed.
It is fixed.
If it is fixed, then palliative resection would be a big procedure for this patient. So,
Okay. Okay. Suppose this patient during the preoperative workup, you stage him as a metastatic disease. Then what will you do?
then I would just palliate the patient. I would go for, again, discuss the patient in the tumor board meeting, and the recommendation would be most probably chemo radiation and palliation.
Palliation.
So,
Okay. Meanwhile, this patient develops hematomesis. Then what will you do? He comes back to you with hematomesis.
So if there is the treatment is symptomatic control,
Okay.
then we can perform endoscopy and assess whether the bleeding is from the tumor or somewhere else.
It's from the tumor.
It's from the tumor. So we'll evaluate if it's a copious amount of bleeding or if it's a large bleeding. Then we'll go for some procedure. We will have to go for palliative resection. Or
is there anything
otherwise
which the endoscopist can do short of the palliative resection? Any other thing?
Yeah, endoscopist can perform hemostasis.
Okay.
And
okay. Okay, your endoscopist is unable to achieve the hemostasis. What will be the next step?
Next step would be to continue resuscitation and then perform palliative resection in this patient.
Before palliative resection, is there anything which you can do? You can offer to the patient?
We will resuscitate the patient. You give him blood, give him PPI on, give octreotide.
Okay, fine. So suppose you have performed the resection with the curative intent. What will be the extent of your resection? Subtotal gastrectomy?
Subtotal gastrectomy would be it would be around 75% of the stomach would be removed.
Okay.
So at least 5 centimeter of margin would be taken proximally.
Would you like to take? Yeah. What about the lymph nodes?
And all the greater omentums, lesser omentum would be removed. Lymph nodes, D2 lymph nodes, all lymph nodes around the stomach, as well as named vessels, they would be removed.
Okay.
And
you have performed this total gastrectomy. So during the follow-up, so what will you do?
During the follow-up, immediate post-operative follow-up, I would look for the wound and look for
He's
the
fine. He's recovering well. Now he
yeah, and
patient is
I
ready
would
for discharge.
I would see the histopathology report.
So what would you
And
like to see in the histopath report?
in the histopathology report, I would like to see I would first confirm that diagnosis, that whether it's the same tumor, and then I would be interested in the margin status, proximal and distal, as well as circumferential margin. I would be concerned about the involvement of the lymph nodes, the number of the lymph nodes which are involved, if there is any lymphovascular invasion or not, and
Okay.
what's the
Okay. So the
histological
total
grade
lymph
and
they will harvest total lymph node adenocarcinoma margin are clear. The total lymph node harvested were eight. Eight lymph nodes were removed, and out of the eight, there were five lymph nodes were involved.
I couldn't hear the first thing that you said.
Yeah.
It's
It's
histopathologically adenocarcinoma.
adenocarcinoma. So the total 8 lymph nodes were removed. 8 out of 8, there were 5 were involved. Margins
So
are clear.
the node involvement is there are two things. This histopathology report that is telling us that there is adequate lymphadenectomy has not been done. One thing, and the second thing is that there is lymph node involvement, so which is a bad prognostic feature. So in this case, I would discuss the patient again in the multidisciplinary team meeting, and I would refer the patient to my oncology and radiotherapy colleagues for further treatment. Moreover, I would keep the patient on continued follow-up in order to see any evidence of recurrence.
Okay, what advice will you offer to the patient?
Well, there will be multiple advice regarding this. There are certain post-operative complications. I would advise against them also. I would give him follow-up advice as well, that he needs to come for follow-up, and we would perform his history clinical examination, and endoscopically. We'll also evaluate endoscopically
So
at regular
he's
intervals.
asking specific advice about the diet. What should he eat or not eat? Specific
He
advice.
should, yeah, he is at the high risk of dumping syndrome. So he should take small meals, and they should not be carbohydrate rich. So that would be
Right.
my advice to him.
Right. Thank you. Thank you.
Thank you.
Thank you very much. Now it's open for the discussion.
आमिर तूने बड़ा अच्छा माशाल्लाह इसको किया है, अच्छा केस था, मुश्किल केस था। सिर्फ जो शुरू में थोड़ा सा ना तू हिस्ट्री और एग्जामिनेशन में काफी मतलब वो रहा है, जैसे क्लूलेस नहीं बंदा एक होता।
Yeah, he was struggling.
मतलब हिस्ट्री में तुझे ना हिस्ट्री में तुझे पूछना चाहिए था वॉमिटिंग किस वक्त होती है, खाने के बाद होती है, वॉमिटिंग का कलर कैसा है,
Yeah.
और उसके कंटेंट्स क्या हैं। ठीक है ना। दूसरा तूने हिस्ट्री में पूछना कि कोई अपना उसका कोई कोई ये गैस्ट्रिक ऑब्स्ट्रक्शन तो समझ आ रही थी इसके कहने से ना। तो गैस्ट्रिक ऑब्स्ट्रक्शन की जो बाकी कॉजेज है, जैसे कोई ट्राइकोबिजोर है, फाइटोबिजोर है, या कोई कॉस्टिक वगैरह इंजेस्ट कर लेते हैं, वो सारी कॉजेज हिस्ट्री में पूछ लेनी चाहिए थी। और एग्जामिनेशन में मोटा मोटा तूने एब्डोमेन को देख के तूने थोड़ा सा सक्शन स्प्लैश का जिक्र अगर कर देता और लिम्फ नोड्स का भी जिक्र कर देता, मेरा ख्याल है थोड़ा सा वो बेहतर हो जाएगा।
ये बहुत अच्छा होता तो बिल्कुल
Exactly.
सही होगा.
So, starting from the history, I intentionally asked you, what question will you ask? You asked me, I will take a detailed history. So I was intentionally asked you to just let me know what question will you ask. So I gave you only two symptoms. You can ask the question related to the vomiting. So the different, you can ask the features of the vomiting as it has been highlighted by the Dr. Noman. Similar weight loss, is it with anorexia, right? So what are the underlying? So it's to begin with, it's a vomiting, repeated episodes of vomiting and weight loss for the last 3 months. So that means this problem is persisting for the last 3 months. So it's most likely it's a gastric outlet infection, or CA esophagus, or it could be caustic injury related to the stricture. So these things, based upon these things, you can ask more questions.
जी बिल्कुल सही है. ये वॉमिटिंग जो है बेसिकली इसकी जो वही है कि मुझे पूछना चाहिए था कि इज इट प्रोजेक्टाइल और नॉन प्रोजेक्टाइल. इफ इट इज प्रोजेक्टाइल वॉमिटिंग तो फिर ये यही दो तीन चीजें
Containing
बच जाती हैं.
undigested food particles.
हाँ, देन इट वुड बी जो है बिलियस नहीं है तो देन इट इज गैस्ट्रिक आउटलेट ऑब्स्ट्रक्शन. दो ही कॉजेज इसकी मोटी मोटी हैं. वन इज कार्सिनोमा, अदर इज जो है सेकेंडरी टू पेप्टिक अल्सर डिजीज.
सर मेरी एक सबमिशन है इसके बारे में.
Yeah.
This gastric because the history was vague with just weight loss and vomiting.
Repeated for the last 3 months.
Yes, you must ask about the contents of whether it is bilious and non-bilious first, because causes of bilious vomiting are different and non-bilious are different. And secondly, you must also keep in mind that carcinoma of head of pancreas, if it invades duodenum, it can also present with same symptom, weight loss, vomiting. So you should also keep in mind the tumor markers of these tumors.
Yeah.
Always, whenever you are talking of tumors, always keep in mind tumor markers as an investigation for laboratory evaluation in the tumor. So
बस इसका स्टमक का तो नहीं है ना कोई भी.
स्टमक का नहीं है, पेंक्रियाज का है.
पेंक्रियाज का CA99 है. ठीक है.
Right.
99
हाँ,
है.
लेकिन जब इसको एंडोस्कोपी में नजर आ गया ट्यूमर तो
हाँ.
फिर को उसकी मार्कर की
हाँ,
जरूरत नहीं
फिर तो वो
रही.
नहीं रही. So once endoscopy, it's 6 to 8 biopsies, multiple you need to take 8 biopsies. So you need to ask more information for the gastroenterologist. For example, where is looking for it? It was in the distal stomach, but you need to ask whether it's located within, what is the relation with the gastroesophageal junction? What is its epicenter? It is within the 2 centimeter of the gastroesophageal junction or not. If it is within 2 centimeter of the gastroesophageal junction and it is involving the gastroesophageal junction, it is staged as a CA esophagus. And then what is the type of the tumor? Is it intestinal or it's a diffuse? Because of the diffuse gastric carcinoma, it has worse prognosis. Right?
Secondly,
so,
my point is, once teaching was, whenever there is gastric carcinoma, you need to have, if you have curative intent, then you need to do radical gastrectomy to remove all the tumors. Why have you done? Why have you done partial gastrectomy in this case?
No. He because it was distal. It was stomach of the distal gastric cancer.
Distal stomach. Yes.
Yeah. So the subtotal gastrectomy is fine. So even they're the randomized control trial, they compare the subtotal gastrectomy versus the total gastrectomy. So there is no much difference in their overall survival.
Okay.
Right. So
subtotal gastrectomy.
You just need 5 centimeter proximal margin.
Yeah. 5
बेयर एरिया की जो लाइन है ना, जो बेयर एरिया ऑफ आप कह लें जो है स्टमक, वहां से जो है बेसिकली एक लाइन आती है जिसके ऊपर आप अपना वो बेस करते हैं. यानी ये बेसिकली पॉइंट होता है जहां से आपकी शॉर्ट गैस्ट्रिक और ये जो दरमियान में जो इनके दरमियान आता है ना, गैस्ट्रोपिप्लॉइक के दरमियान जो एक एरिया आता है, इसको बेयर एरिया बोलते हैं.
ठीक है.
वहां से बेसिकली लाइन आती है. ये तकरीबन आप कह लें कि अपर 25% से फंडस के नीचे आती है. तो वहां से नीचे आपने 75% वो निकालना है और इधर से आपने जो है ना ड्यूडेनम का 2 सेंटीमीटर
और डिस्टल कितना होती है? डिस्टल मार्जिन
सर ड्यूडेनल बल्ब से 1 सेंटीमीटर आगे आपने जो है वो यानी D1 के ऊपर आपने रिसेक्शन कर सकते हैं इसकी।
और डिड्यूनम का प्रोक्सिमल स्टम्प बंद करेंगे इसको
या
और डिड्यूनम का
बिल्कुल
स्टम्प बंद करके।
और आइडियल
और विद फीडिंग
आइडियल
टिश्यू
इसमें एंटी कॉलिक होती है ना, गैस्ट्रोटोमी एंटी कॉलिक होती है।
या एंटीकोलिक।
एंटीकोलिक सर उसमें जब ये आप वही करेंगे पैलिएटिव जो है, इट्स पैलिएटिव इज एंटीकोलिक।
अच्छा, नहीं वैसे भी
गैस्ट्रोजिनोस्टमी
इसमें एंटी कॉलिक।
गैस्ट्रोजिनोस्टमी जो है सर विद रू एंड वाई बाईपास करेंगे या सादा कर देंगे?
नहीं विद रू एंड वाई होगी, वो तो रू एंड वाई करनी है।
तो
वन
वो
बाय
ये
बाद,
बोलना
अदरवाइज
चाहिए।
दिन में रिफ्लक्स होगा फिर
हाँ,
जो
क्योंकि
आप
अदरवाइज
टोटल की है।
सिंपल गैस्ट्रोजिनोस्टमी इज नोटोरियस फॉर
वो तो
रिफ्लक्स ऑफ द
पैलिएटिव के लिए ऑप्शन है ना। पैलिएटिव अगर आपने करनी है तो उसमें फिर आप जो है यू गो फॉर एंटीकोलिक, क्योंकि रेट्रोकोलिक जो है पीछे ट्यूमर होता है तो इट कैन अगेन इन्वॉल्व द गैस्ट्रोजेजोनोस्टमी एज वेल, और उधर भी ऑब्स्ट्रक्शन कर सकता है। तो जब आपने पूरा निकाल दिया तो फिर उसके बाद जो है में, हाँ ये है कि जी स्टमक बेड में जो है रिकरेंस का चांस होता है। इसमें साथ आपने जो है वो निकालना है ग्रेटर लेसर मोमेंटम निकालना है, लिम्फ नोड्स निकालनी है लेवल 2 की पूरी और लेवल 3 की कुछ, और फिर उसके बाद जो है क्या नाम है इंटीरियर पैंक्रियाटिक कैप्सूल निकालना है, और जो जो है ये ट्रांसवर्स कोलोन की मेजेंट्री है उसकी एक लीफलेट जो है जो ऊपर वाली है वो
सर
निकालनी है।
अगर एग्जामिनर पूछे कि ये आप काम कर सकते हैं तो उसको क्या बताना है? ये तो बड़ा ना
सर सर्जिकल
स्पेशलाइज्ड।
ऑन्कोलॉजिस्ट को बुलाना है हमने।
हाँ,
नो
क्योंकि ये जो
करने को तो हाँ ये है
ये जो
कि
गैस्ट्रिक कैंसर की रिसेक्शन है, ये तो अमेरिका और बरतानिया वाले भी नहीं कर सकते, जापानी करते हैं सिर्फ इस तरह की रिसेक्शन जो हम बोल रहे हैं ना।
हाँ, तो इसमें गाइडलाइंस भी यही है कि D2 रिसेक्शन वहां पे होगी हाई वॉल्यूम सेंटर में, जो कि द सर्जन द सर्जिकल टीम दे हैव एनफ एक्सपीरियंस वहां पे। अदरवाइज D1 गैस्ट्रेक्टमी इज फाइन, पर्टिकुलर फॉर द वेस्ट। ये जापान और बाकी वहां पे है जो D2 और वो करते हैं। एनीवे, टू बिगिन विद upper the endoscopy, you confirm the diagnosis of gastric adenocarcinoma. The next investigation is getting the contrast and CT scan. Now, based upon this, you will see whether there are any metastatic disease, whether it's locally advanced, or it's a metastatic disease. If you are suspecting it's early versus advanced, it's early disease, then you go for the endoscopic ultrasound to stage for the T stage and the lymph node. If it's obvious it's an advanced disease, so then there is no much benefit of getting the EUS, right? So there's indication of EUS when you will go for the EUS. So once you have done this contrast and CT scan, so the next obviously it's going for the your PET CT scan. So if there are no distant mets obvious on the CT scan, you go for the PET CT to see whether any distant metastasis. So it's a negative, then the staging laparoscopy with cytology, because if the cytology is positive, that is a contraindication for the curative resection. Now, once you have done this, so at the same time, you need to assess the performance status of the patient. You need to see whether the patient is medically fit enough to undergo this surgery or not. And the nutritional, you need to build up the patient, need to optimize the patient. So then obviously going for the with the curative intent D2 resection, that is to be done in the high volume center. D1 resection you can do. If someone asks me what will you do, I will say I will respond with D1 resection, because I don't have the experience of doing the section at
नहीं फिर उसमें सर आप जो है ना
Understand?
वो ये अपनी उसकी वजह से आप पेशेंट को तो वो
हाँ,
यू विल नॉट पुट
बेहतर,
पेशेंट एट डिसएडवांटेज।
yes,
तो
better
अभी
see,
ये है कि अगर आपने वो करना है तो देन यू से कि जो है आई
send
वुड सेंड द पेशेंट टू
send
हायर वॉल्यूम सेंटर
arrival
फॉर D2 रिसेक्शन।
D2
अगर वो कहता
yeah,
है जी कि कैसे करेंगे तो फिर आप टेक्निक बता दें कि
okay,
जी ये इस तरह से करेंगे। लेकिन
okay,
ये अगर एक इंफीरियर ऑप्शन को हम कहें कि जी मैं मानूंगा क्योंकि मैं ही कर सकता हूँ, तो ये कोई क्या वो हर्निया तो नहीं है ना कि जी
हाँ
बंदा कहे जी लैप जो है वो नहीं करता तो मैं ओपन करूंगा, तो वो
open
कहेगा कि चलो
you're
ठीक है,
right
क्योंकि
you're right
दोनों इक्वली गुड हैं। लेकिन इसमें तो ये है कि सर्वाइवल उसका अफेक्ट हो रहा है। अगर आप
बिल्कुल
D1 कर देते हैं तो उसमें तो आपने जो
Secondly,
लिम्फ नोड कम बताया, अब इसमें भी लिम्फेडेनेक्टमी भी मेरे ख्याल दोबारा होगी फिर।
no it's what is the optimal number what is the recommendation
आई थिंक 14 है या 12 है, 12 है।
16 lymph
6
nodes ठीक है 16 lymph nodes है। अब ये तो हमने we have followed this staging pattern। अब ये होगी clinical staging ठीक है इसे clinical staging then is pathological staging जो P staging आती है P staging with Y new adjuvant chemotherapy then treatment response ये आपने सारे उसके बाद में पूछना है जो हिस्टोपैथ के ऊपर जो चीजें देखनी है कि न्यू एडजुवेंट मिली या नहीं मिली बाकी जो चीजें एनीवे दूसरे वाला था और जो एल्गोरिथम हम जा रहे थे अर्ली अगर अर्ली ऑब्वियसली इट्स वेरी डिफिकल्ट टू पिक इट द गैस्ट्रिक कार्सिनोमा इन अर्ली स्टेज बट if it's carcinoma in situ it's a T1 lesion which is confined to the mucosa so endomucosal resection
एंडोस्कोप
submucosal dissection so that is sufficient for the lesion which are less than 2 centimeters. But before that, you need to get an EUS. If you are planning endoscopic mucosal resection, EUS is must. So you need to see whether the submucosa involved or not, whether lymph nodes are involved or not. At times, you need to get FNAC perhaps FNAC of the lymph nodes. So for the early gastric carcinoma, for the advanced gastric carcinoma, the patient has presented with the obstruction, for example, in the preoperative phase. So what you can do is you can just ask the endoscopist to put in the self-expanding metallic stent. That is one option. The other option is percutaneous or endoscopic guided tube placement, just like a peg tube. You can do that. If it is the obstruction is proximal, if the obstruction is distal, so if you cannot, the endoscopist cannot place the stent, then the option is if the patient is having, particularly there's expected survival is long. Patient has you are expecting that patient can survive for a few months, more 4 6 months, then go for the gastrojejunostomy. But at operation, if you find yes, okay, you cannot find some sufficient amount of the stomach where you can perform anastomosis. So what you can do is you can perform a venting gastrostomy. Venting gastrostomy is just like a tube gastrostomy. You place a tube so that the postoperatively patient don't develop the vomiting. Now the aim is to relieve his symptoms and at the same time perform a feeding jejunostomy and come out. And later on, the
okay,
patient will require, depending
okay.
on
What should be the minimum lumen or anastomotic length for gastrojejunostomy? 5 or 7 centimeter? How much?
at least stoma. What should be size the stoma? I think it's a 5 centimeter. Why it should be
मेरा ख्याल
wide
ये कि
stoma.
5
Otherwise, it will again occlude. If this growth is such that you are unable to find this uh, this uh, much of the length, so it will again it will lead to the stenosis. So they
What do
are
you say that
recommending venting gastrostomy.
isn't it better to perform just feeding jejunostomy?
So
Because
patient post
you
right. So the postoperative, the patient will have the persistent complaint of vomiting because your upper GI secretion, saliva, everything. So patient will keep on vomiting. So if you put a tube, so at least you are relieving his symptoms. So that is the aim of putting a tube into the stomach. That is a venting gastrostomy tube.
वेंटिंग गेस्ट्रोस्टोमी।
Vent. And
अच्छा,
one more thing,
जेजुनोस्टमी की सर कौन सी टाइप्स हैं? What are the types of feeding jejunostomy?
Whittle's feeding jejunostomy.
फीडिंग jejunostomy जो है,
So Whittle's feeding jejunostomy. Whittle's, I think it's Whittle's.
विट्जल होता है ना।
Whitzel, in which you make a tunnel, seromuscular tunnel.
इसी तरह फीडिंग गेस्ट्रोस्टमी की भी 2 टाइप्स हैं, वो कौन सी
Feeding
हैं?
gastrostomy की भी है जिसमें we make a tunnel. What is their name? I just forgot.
एक में टंग का फ्लैप जो है ना, वो जैसे
Yeah.
उसका फ्लैप उठा के तो फिर
Flap
उसकी
का
ट्यूब बनाते हैं।
ऊपर लेके आते हैं. Yes.
हाँ,
I just forgot the name. तो उसमें वो करते हैं. अब उसके बाद क्या करना है? What more thing? If you are suspecting a metastatic disease, it's a recurrent disease, so get the receptor status. What are those? HER2 new. इसमें if the HER2 new positive है, so then your chemotherapy is is based upon the Herceptin. 2 drugs or 3 drugs, depending upon the performance. Similarly, so mismatch repair by immunohistochemical analysis. वो भी करते हैं उसको. These are the basis for the targeted therapies. ठीक है. तो इस तरह ये मैं जो चीजें करते हैं. Herceptin का तो Bailey, it has been mentioned in the Bailey as well. Herceptin based chemotherapy in these patients. So there's a role of targeted therapy. And similarly, there is a role of liquid biopsy. Liquid biopsy.
जी सर, ये लिक्विड बायोप्सी भी नया कॉन्सेप्ट आया है ये.
हाँ, what is that?
जरा इस पे रोशनी डालें.
वो क्या होता है?
सर ये प्रोबेबली जो है कोई ब्लड का सैंपल है कुछ इस तरह से, जिससे पता चल जाता है कि इसको ट्यूमर है कि नहीं है.
या
उसके अंदर ट्यूमर सेल्स आ रहे होते हैं ब्लड के अंदर.
Yeah, exactly. So the tumors, actually the gastric carcinoma, the tumor, they are shedding the DNA. So they are not cells. Actually, that it's a DNA which is circulating into the blood. So you can detect this carcinoma by just taking blood samples. Particularly
ये हमारे उधर वो प्रोफेसर होते थे केम्स में ना, प्रोफेसर कासी, उनका बेटा है मासूम कासी, यूएसए में.
हाँ,
वो इस पे बहुत काम कर रहा है लिक्विड बायोप्सी पे.
लिक्विड बायोप्सी पे. हाँ, लिक्विड they can identify the mutations. हाँ,
इसका क्या नाम है? लिक्विड बायोप्सी.
Liquid biopsy, yes sir. Then there is role of hyperthermic intraperitoneal chemotherapy in gastric carcinoma. Metastatic है, advanced है, उसमें भी इसका role है, but it's in the clinical trials.
एक हाइपेक है और सर एक पता नहीं सीपेक है या एपेक है. एपेक है.
Hypec and hyperthermic intraperitoneal chemotherapy.
हाँ, वो एक
उसमें जिस तरह उसमें होती है सूडोमेक्सोमा में, पेरिटोनाई में.
Exactly. इसका भी रोल अभी मतलब क्लिनिकल ट्रायल में ये चल रहा है.
सर ये जो सूडोमेक्सोमा पेरिटोनाई की जो एक्सीजन है, इसमें तो पेट में बचता कुछ नहीं है, तो मरीज कैसे बचता है?
नहीं, उसकी बड़ी अच्छी नहीं है. उसकी आउटकम जो है ना, इन द हाई वॉल्यूम सेंटर्स, उसकी मोर्बिडिटी और सर्वाइवल अप टू 80%. इतनी एक्सटेंसिव. हाँ, ओके. 5 ईयर
सर्वाइव तो करेगा, लेकिन अब वो क्या करेगा बाद में?
आई डोंट नो.
उस बेचारे का नमक निकाल दिया, कोलन निकाल दिया, गॉल ब्लैडर निकाल दिया, ब्लैडर निकाल दिया नीचे से, ओवरी भी निकाल दी.
बेले में मेंशन है इसकी एक सेंटर है जिसमें 1000 उन्होंने साइटोरेडक्शन की हुई है. 1000.
नहीं वो कर तो दी होंगी, लेकिन मैं कह रहा हूँ मरीज का क्या हाल होगा पीछे उसके.
Anyway, चलें जी. आज का जो है जो 3 scenarios, Amir, you did very well in all of 3 scenarios. Obviously, there's room for the improvement. So that's why we are here. We are learning from each other. So thank you so much.
बड़ा. हाँ, they were very good. आपने बड़े अच्छे वो scenarios वो किए. इसी गूगली कराते हैं हर दफा. तो ये अच्छा था कि थोड़ा सा शुरू में वो वही बात है कि एक डायग्नोसिस मिल जाए तो फिर थोड़ा सा. हाँ, अनडायग्नोस स्पेसिमेन.
अब मैंने आज रखा तेज नहीं, आज ये था कि स्पीड जरा स्लो रखनी है. स्लो ना, अच्छे वाले जो है ना स्लो रहते हैं.
ठीक हो गया.
हाँ, so इंशाल्लाह. चलें, I will upload these 2 videos tomorrow इंशाल्लाह. कल मैं करूंगा कल, बिकॉज आज तो मेरी ड्यूटी है, तो कल इंशाल्लाह मैं I will upload these 2 videos. So thank you very much sir Noman.
Thank you sir. Thank you sir.
Thank you so much for sharing your experience and sharing your knowledge. Thank you very much. So see you again tomorrow inshallah.
Really grateful sir. Thank you very much. Thank you.